This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology in training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi everyone, it's Jeff Ratliff, Deputy Editor of the podcast with the Neurology Recall for June 2023. Over the past few months, we've been fortunate to have some fantastic interviews about the latest in Parkinson's disease biomarker development. For the June Recall, we'll be bringing those episodes together to get you up to speed on the latest. While some of these studies may not have direct clinical implications that our other topics entail, the explosion of research over the past several months is sure to prompt questions from the patients and families affected by Parkinson's in your clinic. We kick off the recall with an interview between Jason Crowell and Bas Bloom that aired on May 11th of 2023. In this interview, Jason checks in with Bas about the latest in Parkinson's research covering both recent clinical trials as well as biomarker development and digital tracking of Parkinson's disease patients and outcomes. In the second interview, we hear again from Jason as he interviews Lucilla Parnetti about her work studying α-synuclein seed amplification assays in the clinical diagnosis of Parkinson's disease. That episode aired August 1st, 2022. We stay on the topic of synuclein amplification assays with the next interview between me and Andrew Siderowf discussing his team's publication from Lancet Neurology about the heterogeneity of synuclein amplification assay outcomes among a broad patient cohort from the Parkinson's Progression Markers Initiative that aired on May 30, 2023. We finally wrap up this month's June Recall with another interview from Jason Crowell. On April 10, 2023, Jason spoke with Christopher Gibbons about α-synuclein skin biopsies to help with the clinical distinction between Parkinson's disease and multiple system atrophy. Hopefully, these interviews arm you with the knowledge you need to guide your patients affected by Parkinson's as they ask about the future of Parkinson's disease research. Thanks for listening to this month's Neurology Recall. We'll see you next month.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hey, this is Jason Crowell from Norton Neuroscience Institute in Louisville, Kentucky. Thanks for listening to today's Neurology podcast. I'm very excited to welcome Bas Bloom to the podcast today. Bas is a neurologist at Radboud University Medical Center in the Netherlands. Bas recently was the co-author of a paper that was published in Lancet Neurology in January of 2023. The title of this paper is Research in Movement Disorders in 2022, a New Era of Biomarker and Treatment Development. Bas, thanks for joining us today.
Thanks for the invitation.
This is a bit of an atypical interview for us. So we typically cover research articles, and this rather as a survey of several different papers from 2022 that were important in the world of movement disorders. And I'm a movement disorder specialist, so I readily admit my bias here. But what I thought would be useful is for you to kind of hop in the car and take us on a tour around the neighborhood and highlight and point out some of these papers from 2022 that you all describe in more detail in the paper that you published. So what we'll do is we'll go through and touch on several different research areas from 2022 that were important in the world of movement disorders. And please feel free to jump in and share any observations you have. Does that sound good?
That sounds excellent.
So the ones that I wanted to start with have to do with potentially disease-modifying treatments for Parkinson's, which unfortunately did not have positive results, and we can talk more about that. So the Pasadena study, which looked at prasinezumab, and Spark, which looked at cinpanemab. So can you tell us what were these two drugs hoping to do, and what did we learn from these two studies?
As people know, Parkinson's is a relentlessly progressive disease, and while we're good at treating symptoms and signs, there's currently no established way of slowing down disease progression. And one of the great hopes is that by targeting the underlying disease pathology, the pathophysiological process, we might be able to slow down disease progression. And as we've known for decades, one of the hallmarks of the disease is Lewy bodies in the brain that we now know contain pathologically misfolded protein called α-synuclein. And one of the approaches that has been tested now in a number of trials is antibodies that specifically try to target the α-synuclein misfolding by sending these antibodies and hopefully prevent the misfolding from happening. And 2 large studies, as you mentioned, both studying a monoclonal antibody, now been tested in large numbers of participants in a randomized controlled trial. Both studies were published in the New England Journal of Medicine, so very decent journal. And unfortunately, although both studies were well designed, adequately powered with an adequate follow-up, there was no sign of efficacy on clinical outcomes, the Unified Parkinson's Disease Rating Scale, nor on a dopamine scan of the brain, the dopamine transporter scan. So there was no sign of target engagement. There was no sign of clinical efficacy. And obviously, this was disappointing for the field. We've seen many disappointments in the Alzheimer field where targeting amyloid was not always successful, with maybe one exception. But definitely, these were 2 disappointing outcomes in the field of Parkinson's.
So I know this is still a topic of much debate, whether or not targeting α-synuclein is going to be fruitful. We're recording this in late April, and I was just reading last week an opinion piece by Tony Lang published in Movement Disorders Journal, again, discussing this idea of whether or not targeting α-synuclein is the way to go. Can you comment on that? And I know this is opinion, but can you comment on these monoclonal antibody treatments for Parkinson's? Do you think this is something that should still be looked into, or are you in the camp that this is unlikely to be effective with regards to disease modification?
As you said, there's 2 camps, and I'm sort of halfway in between. One camp says, well, how many negative trials do we need before we bin the whole idea of anti-alpha-synuclein treatments? And that's one way to go. What we discuss in our paper in the Lancet Neurology is that there are perhaps 2 avenues to do things better. And one relates to the clinical outcome. I mentioned the Unified Parkinson's Disease Rating Scale, and any listeners who've used this scale in their clinical practice know that this is an observer-based rating scale where you look at symptoms and signs and you give it a score from 1 to 4, which means it's an ordinal scale with fairly big steps. And we know that this clinical scale is subjective to intra and inter-rater bias and variability. So people feel that maybe we've missed the boat by not including a more sensitive, objective, for example, digital biomarker. And what I thought was really interesting, and which did not receive a lot of attention in the paper, is that in the Pasadena trial that tested the prasinezumab, they also included an exploratory digital outcome. And specifically what they did is they used the participant's smartphone to deliver a series of tests on a very regular basis, where people were asked to hold the phone in their outstretched hand to measure tremor, to make alternating movements to test for bradykinesia, to make a sound, and to listen to the voice. And interestingly, in a separate experiment, they validated this digital outcome by showing it showed a fairly decent correlation to the Unified Parkinson's Disease Rating Scale. But now the difference being that you can deliver this much more frequently and at home on a continuous basis. And what is interesting is that even though the clinical outcome did not show any difference in the Pasadena trial, the digital outcome did show a benefit for both active treatment arms. They compared a low dose and a high dose to placebo versus the null treatment, the placebo treatment. The only concern here is that the higher dose had a smaller effect than the lower dose. So that is not really intuitive. And of course, this is only exploratory. So you cannot overinterpret these findings. It's at best exploratory. But I think it does raise the question whether future trials should continue to rely on this complex, subjective, and variable scale, which is called the UPDRS, or whether we should now increasingly move towards digital outcomes, because there are advantages. It's objective. It can be delivered much more frequently and at home. And I'm a strong believer in digital outcomes. So I think one of the major, results of the Pasadena trial is that it shows the potential of a digital outcome. Now, obviously, what you need to show is that a change in a digital signal means anything to the participant. And what the FDA is now increasingly demanding is an outcome which is neither a clinical rating scale nor an arbitrary digital signal, but something that's meaningful to the participant. Can I now fry an egg with this tremor? Can I go out and about and do my shopping independently? This is where we need to go to clinically relevant outcomes. And ideally, we build digital measures that show some correlation to these clinically meaningful daily activities for patients. And this is a field that's now up and coming. We're also active in that field. And again, I think this is one of the major sort of outcomes of this negative trial, to my mind.
That's a great point. And let me follow up on that. So in this study, they were using some kind of app in a handheld phone. Is that correct?
Yeah, that's correct.
And are there other types of devices currently being employed that can facilitate measurement of some kind of biomarker other than an app and an iPhone?
Yep. Well, one paper is discussed in the Lancet Neurology editorial that I wrote, by the way, with my good colleague and friend, Christine Klein. Her name should be mentioned in this podcast, of course. The other study that we mentioned, and I thought this was really interesting, used radio waves by a device that was attached to the wall in the house of the participants. So by and large, these digital biomarkers are now based on body-worn sensors, whether this be a smartphone or maybe a smart watch or a sensor attached to the waist or to the chest or to the ankle. The big issue there is compliance. And what Ray Dorsey and his group have shown is that radio waves transmitted from a device attached to the wall can actually measure movements while people are moving out and about in their own homes. And they specifically looked at gait. In a separate paper published in another good journal, they looked at breathing patterns. And apparently, these devices can unobtrusively measure the quality of gait in people's homes. It did not show a good correlation to disease progression. That was a bit of a downside, but it correlated reasonably well to the MDS-UPDRS rating scale. And the great advantage here, of course, is that you can now measure people's quality of movements without having to attach anything to their body. So potentially, this will be very good from a compliance standpoint. Disadvantage, of course, being that you can only measure people in their homes and not, for example, when they go out on the street to do some shopping. But it's an interesting development, and it just shows that this whole field of digital biomarkers is developing rapidly. And for all the people listening today, this will impact in the short term only on clinical trials, where these digital outcomes will be used as secondary exploratory outcomes. I don't think that in the short term it's going to affect your clinical practice, although I hope and I would predict that within, say, 5, maybe 10 years, we will come to a point where the patient comes to your clinic showing a readout of their smartwatch, their smartphone, maybe the radio waves transmitted from their wall, so that you can interpret that signal in a meaningful way and then adjust your Parkinson medication accordingly. I think that time will ultimately come, but it's not here yet.
Bas, you also in this paper mention some other biomarkers for Parkinson's disease that are still being developed. And again, we're recording this in mid to late April, and the American Academy of Neurology annual meeting is currently underway. And so some results are being discussed there. But at least in this paper, can you talk about any of those biomarkers that stood out to you?
What you would like to show is the nature of the underlying disease process in the brain. And we mentioned α-synuclein as a key protein that misfolds and clots in the brain of Parkinson patients. We knew already that there are tests called seeding assays, where in a prion-like manner, you very cleverly ask the protein to replicate itself. So it's a very sensitive way of showing minute concentrations of alpha-synuclein in body fluids. And this had already been demonstrated in cerebral spinal fluid, for which you need a lumbar tap. But now a new paper in Brain showed that this alpha-synuclein can now also be measured using this seeding assay in blood. And that is, of course, very important. They were able to show that it separated Parkinson patients from controls in a rather good way. They were even able to show that the alpha-synuclein that they measured had a pathological structure. And that's important because one of the other reasons why the Pasadena trial and the Spark trial were negative is that maybe people were included in those studies that never had an alpha-synuclein problem to begin with. So if you now have an assay, ideally one in blood, because it's readily accessible, that can show the nature of the underlying disease process and where you could prove that your participant actually has an alpha-synuclein issue, then you would be a good candidate for an alpha-synuclein antibody study. And you just mentioned the AAN, and I'm unfortunately not in Boston, but I know what they're discussing because last week another paper came out in the Lancet Neurology based on the PPMI data, where they used another alpha-synuclein seeding assay, this time in the cerebral spinal fluid, to show two things. One is, if you have idiopathic Parkinson's disease, i.e. not any of the known genetic causes of Parkinson's, the test is positive in around 96% of participants. But if you have LRRK2 Parkinsonism, which is one of the autosomal dominant causes of Parkinson's disease, the test was only positive, I'm saying this off the top of my head, in some 60 or 70% of participants. Now, if you hadn't done those tests and you had included LRRK2 positive individuals in your trial, many of whom never had an α-synuclein problem, you would be underpowered to detect a real effect. So the fact that we now know that Parkinson's is a heterogeneous disease in terms of pathophysiology, and that we have tests in CSF, but perhaps also in blood, as this new paper in Brain was showing, you can identify the right candidate for the right study. And that, I think, is a major development, again, for trials, not so much for clinical practice yet, but it will allow to the right people in the right studies.
Very good. And so, Bas, any other highlights from the research world and movement disorders from 2022 that you think we should know about?
Well, two things that I think are attracting a lot of attention. One is the close link between Parkinson's and diabetes. A number of studies have already suggested that there's a link between the two. A new paper in movement disorders showed that people with Parkinson's and concurrent or comorbid diabetes had faster disease progression, which again confirms that there's this link between Parkinson's and diabetes. And that is a strong further motivation to use anti-glycemic drugs as a potential way to modify disease progression in Parkinson's. To my mind, one of the most promising compounds around is exenatide. There was a paper in The Lancet by Tom Fultoney's group in England to show that exenatide was associated with a slowing of disease progression in Parkinson's in a phase 2 study. Tom is now performing a phase 3 study in England using both clinical outcomes and digital outcomes. And I think out of all the many compounds that we're currently testing for possible disease-modifying potential, I think these anti-glycemic, these diabetes drugs hold the greatest promise. So I think that's one thing that people should be aware of. And also, maybe for those in daily clinical practice, to just be aware of these comorbid conditions. You know, people with Parkinson's don't just have Parkinson's disease, they typically have multiple other conditions, and one of the common ones is diabetes. The other thing that I would like to mention, because this is a question that comes to my desk in my clinical practice a lot, is the relationship with SARS-CoV-2, the COVID infection. There have been a number of case reports where people following a COVID infection developed Parkinson's disease shortly thereafter, triggering a debate whether COVID, or the SARS-CoV-2 virus, which we know is neurotropic, could also affect the basal ganglia and thereby maybe cause Parkinson's disease. There's been critique of these studies. We actually published 2 cases where we showed that people who developed Parkinson's shortly after COVID, in fact, already had prodromal Parkinson's, if you listened carefully to their stories. So maybe COVID just unleashed what was already about to happen because of the stress associated with a COVID infection. But there's a new paper in movement disorders where they looked in a mouse model where they infected mice, rodents, with COVID and subsequently exposed the same rodents to a neurotoxin called MPTP, which we know is a potent toxin for the substantia nigra, and showed that mice with prior exposure to COVID were more susceptible to a neurotoxin that caused Parkinson's. So jury's still out there. We're not certain whether COVID is definitely leading to Parkinson's all by itself, but it could potentially interact with other triggers in our environment, jointly lead to Parkinson's. I don't think we've seen a massive further increase in the number of new cases with Parkinson's since COVID, but time will tell. We need to monitor this, and I think it's an interesting basic observation.
Terrific, Bas. Really helpful tour of some of the updates in research and movement disorders over the past year. To our audience, again, the title of this paper published in Lancet Neurology in January of 2023 is Research in Movement Disorders in 2022, A New Era of Biomarker and Treatment Development. Again, this was co-authored by Christine Klein and Bas Bloom. We've been speaking to Bas. Bas, thanks so much for joining us. We really appreciate your time today.
You're more than welcome.
Hey, this is Jason Crowell from Norton Neuroscience Institute in Louisville, Kentucky, and I'm very excited to welcome Lucilla Parnetti to our podcast today. Lucilla is a neurologist and the director of the section of neurology at the University of Perugia in Italy, and we invited her today to talk about a paper published in the journal Neurology titled α-synuclein Seed Amplification Assays for Diagnosing Synucleinopathies, the Way Forward. Lucilla, first of all, thanks for joining us today. Really excited to have you with us.
My pleasure.
So in just a minute, we will retrace our steps and talk a little bit about the background of this research. But before we do, I just want to make sure that we all know what we're talking about. So briefly, could you just describe what a seed amplification assay is and how it might be used to diagnose, say, Parkinson's disease or a synucleinopathy?
Seed amplification assays are actually techniques that exploit the prion-like properties of proteins prone to aggregation present in biological fluids. Thus, thanks to these techniques, even very low amounts of pathological aggregates present in biological fluids or tissues can be amplified and so detected. These techniques have been initially developed for the detection of the prion protein characterizing Creutzfeldt-Jakob disease. And these techniques, originally applied to this disease, in recent years have been readapted in order to specifically misfolding-prone α-synuclein in biological fluids and tissue. And what is important is that the results achieved in different laboratories when applied to α-synuclein have shown really impressive results. They have shown that these techniques represent the most promising biomarker of synucleinopathy in our hands, reaching sensitivities and specificities for detecting Parkinson's disease versus controls or other neurological disease above 90%.
Terrific. And Lucilla, if I understand you correctly, you mentioned that you're exploiting the prion-like nature of these proteins. So we have lots of different, proteinopathies in neurology, neurodegenerative diseases associated with alpha-synuclein or amyloid or tau. So am I right in saying that when you say you're exploiting the prion-like characteristics of these proteins, you mean the ability of the protein to misfold and actually induce that same misfolding in the other protein? Is that accurate?
Yeah, in the chapter of prion diseases, such as Creutzfeldt-Jakob disease, prion protein undergoes a conformational transformation that leads to aggregation. This is the first part of the story. This aggregated structure further promotes the conversion of other prion proteins into pathological conformation. In this way, it is triggered the so-called misfolding cascade. And the toxicity induced by misfolded prion species and the loss of the function of the physiologically functioning prion protein represent the main drivers of the neurodegenerative process. Other proteins, such as alpha-synuclein, A-beta, tau, share some feature with this with the prion protein, such as the ability to form toxic oligomers, fibrillary aggregates and plaques, and the ability to propagate their misfolding feature from cell to cell. This is the core feature. In all these proteinopathies, different from prion disease, let's say, the pathological accumulation and misfolding processes are, of course, much slower than in Creutzfeldt-Jakob disease. And they start years before the onset of symptoms. Actually, as opposite to Creutzfeldt-Jakob disease, in these diseases, we are speaking about Parkinson's disease, Alzheimer's disease, other neurodegenerative disease. In this disease, I was saying, we face with long, almost asymptomatic phases in which the clinical diagnosis is definitely difficult in absence of an objective biomarker.
Right. And so before we move on, I also want to just briefly mention for our audience that to learn more about the story of prions and what we've been talking about thus far, I encourage you to check out the interview we did with Stanley Prusiner back in October of 2019. Stanley Prusiner, of course, was the recipient of the 1997 Nobel Prize for discovering prions, and we had a fascinating conversation with him back then on October 14th, 2019. But to pick up here, Lucilla, so you're right. We don't have great biomarkers for Parkinson's disease. In the background of this paper, as I was reading it, you talk a little bit about how other proteinopathies like Alzheimer's are further ahead than Parkinson's in terms of having biomarkers. Could you briefly talk about that before we get into these seed amplification assays?
Alzheimer's disease represents a sort of front disease, I would say, in the field of neurodegenerative diseases for the main aims achieved so far. In the last couple of decades, in the context of Alzheimer's disease, we have been able to definitely show that in our cerebrospinal fluid, measuring the levels of A-beta peptides, A-beta 42 and A-beta 40 exactly. And by measuring the phosphorylated form of tau by means of well-established immunoassays widely available, and measuring these two biomarkers, which represents the signature of the disease because they are corresponding to the brain amyloidosis and to brain neurofibrillary tangles burden, we have proven that they are excellent biomarkers and that they are not depending on the clinical stage. So if I have a CSF profile A+, T+, which means showing the presence of amyloidosis and tauopathy, I can be defined as affected by Alzheimer's disease, and then I specify at which stage. It might be even asymptomatic, so preclinical stage, or very subtle deficits. And the possibility to make a so early and precise and accurate diagnosis in Alzheimer's disease has given us the chance also to properly select people suitable for pharmacological intervention with these novel disease-modifying therapies. And more recently, following these achievements, we have been applying the measurement of these physiopathological biomarkers of the disease also in blood. And here we are quite well poised, I would say, for possibly in a short period of time having available to diagnose this disease even with blood measurement of these biomarkers. We have now to follow a similar route for Parkinson's disease and for synucleinopathies. And in order to follow this model, let's say, of Alzheimer's disease, we have started by measuring total α-synuclein, since α-synuclein is the main actor of this chapter of diseases, in CSF, using, again, immunoassays. But this approach has shown very little diagnostic value of this biomarker, since what we measure as the total amount of α-synuclein detectable in CSF just reflects unspecifically the synaptic disruption taking place in our brain. So it has not a sufficient sensitivity and specificity for being a good candidate for diagnosing Parkinson's disease. Also, we have been able, with longitudinal studies, to see that this total α-synuclein we measure in CSF then indifferently increases along time with the duration, and is a reflection of the duration of different neurodegenerative diseases. Again, showing that the synaptic disruption going on and increasing a long time gives higher levels in CSF of this biomarker. Then we have moved to the attempt to measure the oligomeric forms, the oligomeric species of α-synuclein in CSF, again by immunoassays. But again, from one side, we got some more specific results showing that the trend toward the increase is mostly observed in Parkinson and other synucleinopathies. But unfortunately, the diagnostic performances are still suboptimal. So, as a consequence, the diagnosis of Parkinson's disease is unfortunately at present made on a clinical basis, which means at a quite advanced symptomatic stage, and still with a significant possibility of a misdiagnosis, of being not accurate and precise due to the possibility that the clinical picture still is common or may be present in other disorder different from Parkinson's disease.
Great. So my understanding then is that we would hope these seed amplification assays or some other test might be able to help us diagnose Parkinson's earlier in the disease course. And so let's talk about these seed amplification assays. In the paper, you described two different ones. So RT-QuIC and protein misfolding cyclic amplification. Could you talk a bit about how these work and how successful they are for alpha-synuclein?
Seed amplification assays actually mimic the misfolding cascade that we were speaking about for the misfolding cascade process which takes place in prion disorder, let's say. And the aggregation process is further sustained by applying cycles of sonication, let's say of vigorous shaking in presence of beads, which may be glass or silica beads. In RT-QuIC, this aggregation process can be monitored in real time by measuring fluorescence of a particular dye named thioflavin T. And the resulting fluorescence trace can be analyzed to determine the presence of pathological aggregates present in the biological matrix under exam. And I get a sort of sigmoidal curve in which you have the first phase when you just are in the phase of promoting the reaction. Then the reaction starts and reaches a plateau. And you can see how steep is the line when the reaction starts, or how fast or how slow it is. In PMCA, originally, for it was used hamster prion protein instead of a recombinant protein. And the amplified aggregates obtained, were detected by Western blot. So this was the original different stories of the two techniques. But if we go to the context of alpha-synuclein, starting since 2016, the story actually starts. Protein amplification assays have been applied to detect misfolded alpha-synuclein in the CSF of patients affected by synucleinopathies by two independent groups, which respectively named the novel assays alpha-synuclein PMCA and alpha-synuclein RT-QuIC. But although the assays had different names, they both made use of recombinant alpha-synuclein and real-time monitoring by thioflavin T fluorescence. So we can actually say that despite some differences in the analytical protocols, the assays were actually similar and produced also similar results, both in terms of sensitivity and specificity. Since 2019, we speak about the seed amplification assay in order to do not insist on these different acronyms, which actually refer to very similar and substantially equal techniques, let's say.
So would this seed amplification test do anything to distinguish one synucleinopathy for another? My guess would be not, unless there's something intrinsically different about the synuclein associated with, say, Parkinson's disease or the synuclein associated with Lewy body dementia or some other synucleinopathy. Unless the protein's different, I would imagine that the test would not be able to differentiate between the two. Is that right?
We have an urgent need of robust synucleinopathy biomarkers because we actually do not have other tools for reaching this early and appropriate diagnosis of these diseases. And these techniques have been recently shown also to detect what we call prodromal Parkinson's disease. Recently, subjects affected not yet with motor disturbances. And with respect to the differentiation among different synucleinopathies, here we have to introduce another concept. There are many studies now which are able to confirm that different alpha-synuclein strains are present, for example, in Parkinson's disease with respect to multiple system atrophy. And we know that they are two very different, biologically speaking, disease in terms of cell affected and type of synuclein playing the role. Also, the biospecimens obtained in these diseases have shown to produce also different and distinguishable fluorescence traces in alpha-synuclein seed amplification assays. So this is another route we are, many groups, I would say, are following. And to show that also on the neuropathological level is clear that, for example, for dementia with Lewy bodies, that this disease is associated to a particular alpha-synuclein strain different from Parkinson's disease, but in this case, still there are difficulties for the seeding aggregation assay to probe it. So there are many different evidences, I would summarize like that different conformational strains are characterizing these different synucleinopathies.
Great. And wrapping up here, Lucilla, what would you say remains to be seen in terms of this testing before we could use it clinically, in an exam room, diagnosing someone with Parkinson's or not? What are the next steps before we could use this on a clinical basis?
The clinical application is, of course, our major goal. But we have to be very honest and say that clinical application per se is still not close, because we have many issues with respect to the definitive standardization of the method, the possibility to do with exactly the same protocol these assays, and to have reference material. First of all, the type of recombinant alpha-synuclein should be, let's say, the same in any protocol, in any laboratory. And so when we jump to the clinical setting, I would say what I still do with any patient who undergoes cerebrospinal fluid tapping for having a biomarker assessment. And so first we have the duty to say to the patient that it is important, independent of the actual availability of a good biomarker, to go deep in the diagnostic molecular profiling in any patient for, of course, in a well expert center, in order to contribute to the biomarker-based diagnosis of neurodegenerative diseases. So I can have the perfect diagnostic good biomarker, but I can measure many different biomarkers, and in expert hands, this already gives a contribute to the knowledge, a contribute to science, a contribute to better characterize the patient. And the patients should be, I would say, encouraged to contribute to this great mission, I would say, in the field of neurodegenerative disease. After that, with respect to Parkinson's disease diagnosis, I would explain that although we are still far from a routine test for early and accurate diagnosis of Parkinson, but still we can have other information, CSF tapping, we can exclude the Alzheimer's contribution, and we can have other information according to the lab expertise. And then I would say that also we have finally in a quite good, position for the best biomarker, the possibility to measure also the aggregation-prone α-synuclein. And we can do that. We still can't apply it as a routine and definite diagnosis, but we are going to do that. And so just to conclude, we have to be first, making the diagnosis, we have to convince the patients that this is a cultural battle. And they have to be informed about, and they should contribute by definition to this, to win, let's say, this battle, and also keeping them informed about the advancement of our research.
Terrific. To our audience, I encourage you to check out this paper in the Journal of Neurology. Again, it's titled Alpha-Synuclein Seed Amplification Assays for Diagnosing Synucleinopathies, The Way Forward. And once again, I've been speaking with Lucilla Parnetti, who is a neurologist at the University of Perugia. Lucilla, I did my best to pronounce your name. I know I probably messed it up, but really appreciate...
You are simply fantastic in pronounce my name.
Well, really appreciate you joining us and talking with us about this research. Hopefully we can have you back in the future when it's a little bit further along as well.
Yeah, it would be my pleasure, and thank you for giving me this opportunity.
Hi, it's Jeff Ratliff with the Neurology Podcast and Thomas Jefferson University. I'm here with Andrew Siderowf, a movement disorder neurologist and researcher from the University of Pennsylvania. And as much as our listeners want to hear these two Philadelphia-based neurologists talk about the best cheesesteaks or speculate on the Eagles, we're actually going to talk about a study that Andrew and his colleagues published in the Lancet Neurology in May of this year, titled Assessment of Heterogeneity Among Participants in the Parkinson's Progression Markers Initiative Cohort Using Alpha-Synuclein Seed Amplification, a Cross-Sectional Study. This study was a cross-sectional analysis of patients in the PPMI, as we'll abbreviate it. More specifically, Andrew and colleagues used alpha-synuclein seed amplification assays to explore heterogeneity among patients in that PPMI cohort. Podcast listeners will remember that Jason Crowell spoke with Dr. Lucilla Parnetti in the August 1st, 2022 episode of the podcast about these seed amplification assays in Parkinson's. And listeners who have been listening more recently will recall that Jason Crowell had a conversation with Bas Bloom on May 11, 2023 about a 30,000-foot view of biomarker development in Parkinson's. And Jason and Bas did briefly touch on this study that Andrew and I are about to get into in a little bit more detail. We'll review some of what these seed amplification assays are with Andrew, as well as talk about how this work builds on what we already knew and some possible next steps as we talk about Parkinson's disease biomarker development. Andrew, welcome to the podcast.
Thanks, Jeff. It's a pleasure to be here.
So, Andrew, I want to cut a little bit to the chase to start us off. And my understanding is that you and your colleagues looked at cerebrospinal fluid of patients in the PPMI cohort, specifically looking at results on these alpha-synuclein seed amplification assays. In that group, you were looking at both patients with diagnosed Parkinson's disease, but also prodromal or quote unquote premotor Parkinson's. You were looking at healthy controls as well as some other cohorts related to genetic causes of Parkinson's. So there's a lot going on with these various cohorts and comparisons. And so before we get into some of the details, what would you tell colleagues is the main primary take-home lesson from this project and from this paper?
If you allow me, I would say there are three take-home lessons from the paper that I'd like to emphasize. The first is that the seed amplification assay in our hands was accurately differentiated people with Parkinson's disease from healthy controls. The second point is that it identified, surprisingly, underlying heterogeneity within Parkinson patients, probably based on whether or not they had Parkinson's due to the typical alpha-synuclein pathology or not. And then the third take-home is that among the non-manifesting carriers and prodromal patients we looked at, people who were at risk but didn't have Parkinson's, we found a relatively high rate of positive SAA, indicating that the pathology for Parkinson's probably has a relatively long latency period before clinical features emerge.
I think those three take-homes are important, and let's try and flesh those out a little bit as we discuss. I hope to start us off and just to refresh us a little bit, if folks haven't listened previously, about what the alpha-synuclein seed amplification assay is. Can you explain what are these assays? And coming into this study, what did we already know about their role as biomarkers in the world of Parkinson's disease?
They're not really new. They've been around for at least the last 5 years, probably longer, because the same technology has been applied to identifying prion proteins in disorders like Jakob-Creutzfeldt disease. But it's an amplification technique, which is a little bit like PCR for genetic material, but rather than applying the amplification technique to genetic material, we apply it to proteins. And the technology, like I said, has been around for about 5 years and often is referred to as RT-QuIC, which stands for real-time quaking-induced conversion, and sometimes is protein misfolding cyclic amplification, as PMCA. But more recently, the field has sort of coalesced around calling both of these techniques seed amplification. And the idea is that tiny amounts of self-replicating misfolded synuclein aggregates, or whatever protein it is, but in our case it's synuclein, from biological samples, and again in our case it's spinal fluid, are multiplied to reach quantities that are easily detectable by standard fluorescent measures. And what happens is that these seeds are bathed in high density of substrate. In this case, it would be alpha-synuclein monomers or tetramers. And there's a self-templating aspect to the seeds so that the seeds recruit the native synuclein to form aggregates in the same misfolded pattern as the seeds. And then there's a shaking event that takes place that would mechanically disrupts the seeds, these larger aggregates, back into smaller seeds again. And then the process is repeated through cycles until there's enough misfolded protein around that it can be measured with standard analytic techniques. As I said, this has been around for about 5 years now, and a number of different labs around the world have been doing it. And the results so far have shown really high sensitivity and specificity in Parkinson patients versus healthy controls, some ability to detect alpha-synuclein in other synucleinopathies like multiple system atrophy, although this is still a work in progress, and probably the assay needs to be modified somewhat to be sensitive to MSA. And so the difference in our study is it was much larger than any of the previous studies. It allowed for analysis of subgroups and also for a much more detailed investigation of prodromal and at-risk individuals.
And so in this study, you looked at more than just patients with Parkinson's and healthy controls. And we touched on it in that first question that there was a lot of different cohorts of patients in this study. And some of those take-home points that you mentioned refer to some of the findings in prodromal Parkinson's or even Parkinson's that is not associated with synuclein pathology. And so could you outline what are the types of patients who were studied in this project and talk a little bit about how they were grouped and why you grouped them the way you did? And then hopefully we'll get into sort of some of that heterogeneity that you guys found.
There were about 1,100 participants in PPMI who gave spinal fluid samples for this study. And the largest group was people with sporadic Parkinson's disease, so Parkinson's disease, patients who didn't carry a genetic variant which is associated with Parkinson's. But in addition, there were a relatively large number of patients that had genetic variants, Parkinson's disease and genetic variants, so either the glucocerebrosidase or the LRRK2 leucine-rich repeat kinase, the most common variants of both of those genes. And there were non-manifesting carriers who had both of those genes. There were prodromal individuals who had, the easiest way to think about them is they were at immediate risk for Parkinson's disease based on either having REM sleep behavior disorder, which is a clinical syndrome which puts people at very high risk, probably 5% per year risk of developing a synucleinopathy, either dementia with Lewy bodies or Parkinson's disease. And also people that had hyposmia and an unexplained loss of sense of smell. And these individuals also had positive DAT scans, so it wasn't just hyposmic individuals, but it was hyposmic individuals who, with few exceptions, also had an abnormal dopamine transporter imaging. So those are the at-risk groups, and then in addition there were two control groups. There were the healthy controls who were not known to have any neurological disorder or symptoms. They were age and sex matched with the Parkinson patients. And then there were also the so-called SWEDs, which were individuals who had clinical features that resembled Parkinson's disease at the time of enrollment, but were found to have normal dopamine transporter imaging and therefore excluded from the Parkinson cohort in PPMI. It's a large, sprawling study with a lot of subgroups. And then we just sort of drill down a little bit. So because there were Parkinson subgroups that included people with sporadic Parkinson's disease and also Parkinson's disease based on genetic variants. And then there were also Parkinson patients with a range of different clinical features. So we were able to look at heterogeneity within the Parkinson patient group. And what we found was that among the Parkinson patients that were very typical, in other words, they had not sporadic Parkinson's disease and had typical features, including the typical loss of sense of smell that we see most of the time in Parkinson's disease. The test was positive over 98% of the time in this group. However, in certain subgroups, the test was positive a lot less. And this is especially true in the Parkinson patients who are LRRK2 carriers. In that group, it was about 2/3 positive, 1/3 negative. And in the sporadic Parkinson's group that had preserved sense of smell, in other words, it did not have hyposmia, and this is not the typical case, again, it was 2/3 positive, 1/3 negative. And so this was sort of the key indication that we had that there's pathological heterogeneity, especially as it pertains to hyposmia versus normosmia and LRRK2 versus the other groups, including GBA, where we saw a very high rate of SA positivity and sporadic PD, also very high.
So as we build on the ability of these SAAs, these seed amplification assays, to differentiate Parkinson's from healthy controls, and you touched on it a little bit, these results from these cohorts tell us a little bit more about the use of these alpha-synuclein amplification assays in prodromal Parkinson's or people with genetic mutations. And it sounds like specifically in the LRRK2 component of this cohort, the identification of alpha-synuclein in this assay was not as significant. And so does that teach us something about the pathology of their Parkinson's, or does that differentiate them from those sporadic Parkinson's patients at the pathological level in some way?
That's exactly right. We think that the synuclein seed amplification assay is detecting synuclein pathology rather than a nonspecific feature of Parkinsonian syndromes like dopamine deficiency. And so we think that people that have a positive SAA have typical Lewy pathology. And we have a few patients in our study who came to postmortem, and the ones that were positive, there were about 15 of them, all had typical Lewy pathology at autopsy. We had one patient who was SAA negative, came to autopsy, and had cell loss, but no Lewy pathology at postmortem. And this patient happened to be a LRRK2 positive and normosmic individual. It was a male LRRK2 carrier who was normosmic. So this is one piece of data. And then if you look sort of broadly at the literature on pathologic heterogeneity in LRRK2, the main take-home is that about 2/3 of LRRK2 Parkinson's patients have Lewy pathology and 1/3 don't. And this is the statistic that's in the published literature. And this matches almost perfectly with the ratio of 2/3 to 1/3 we found with SAA positivity. And there are smaller studies that bear this out also. I think this idea that the SAA assay is detecting synuclein pathology probably needs to be confirmed in larger autopsy series, but it's very consistent with the existing evidence. So the hypothesis is that this is not necessarily a test for Parkinson's per se, but rather a test for a typical Lewy synucleinopathy.
And yeah, that's what I was going to say, sort of in hearing that you have some small groups that definitely point to a possible association between the amplification assay and the ultimate neuropathology that's found on postmortem. But I know that wasn't the primary outcome in this study that you guys are looking to study. And it sounds like further studies looking at this association between the spinal fluid amplification assays and the ultimate neuropathology on postmortem needs to be done at a larger scale to sort of explore some of this heterogeneity at the neuropathologic level as well, correct?
Yes, and we're obviously pursuing this, as patients who are in PPMI, many of them are generously consented to autopsy, and then other groups are also pursuing this same line of investigation. But like I said, the data that's available, there's nothing that's inconsistent with this idea so far.
So I want to start to look ahead based on some of the findings that we've been talking about. So I want to zoom out and look at the implications of this project. And your discussion in this paper focuses on steps to come and further steps, specifically in the realm of Parkinson's research. And we touched on one of those, looking at postmortem association with these assays. But in the broader scheme of developing biomarkers for Parkinson's disease, or even potentially developing disease-modifying therapies for Parkinson's disease, What do the results of this study teach us or inform us to do better going forward?
The main implication for the study currently has to do with research. We think this will be a very useful research tool for identifying people that have typical synuclein pathology who would be the best candidates to participate in trials testing anti-synuclein aggregation therapies for Parkinson's disease. I think it would benefit the participants in these trials because they'd be more likely to benefit from the intervention. It also would benefit the trials because they'd be more likely to find effects if effects are really there, because they would have a homogeneous group of participants who actually have the target pathology. So I think right now this is mostly going to be a research tool which will streamline clinical trials. It has some clinical utility now as a diagnostic, but it will mostly be for people who are very interested to understand their Parkinson's better, and it probably doesn't lead to different therapeutic decisions now. For example, the LRRK2 patients are a good example where a patient that has a LRRK2 variant and typical levodopa responsive Parkinson's would be treated the same whether or not they have an SAA with levodopa or DBS, what have you, whether or not they have synuclein pathology causing their clinical syndrome. And that's true now, but in the future, when we hope that there'll be a rational therapy that specifically targets the underlying pathology, it'll be very important to know whether patients have typical synuclein pathology or not, because you would make therapeutic decisions based on pathology rather than based on clinical symptoms.
And pivoting over to our listeners who are clinically oriented, taking care of patients with Parkinson's disease, and I would say this reflects my experience and probably yours as well, but I think it's safe to say that our patients with Parkinson's who, as a rule, tend to be very informed about what's going on in the world of Parkinson's research are going to have questions about these results and the impact on their own lives with Parkinson's. And you touched on it a little bit that these results are not going to affect our on-the-ground clinical treatment decisions. Levodopa is still going to be a primary symptomatic therapy that we're going to use. But now stepping into your role as a movement disorders clinician, can you tell us how the information and the knowledge gained from this study is affecting the conversations you have with your patients when they bring up this study or they read a press release or whatever it may be? How are you answering their questions about the clinical impact of this study?
I've been saying that this is primarily a research tool now, and that it has a potential to be a diagnostic, but it probably isn't going to replace existing diagnostics, like a thorough neurologic exam, which is still the best diagnostic test for Parkinson's disease, or ancillary tests like a DAT scan. But in the future, it may. And one thing that we didn't do in our study, because it's cross-sectional, but it's possible that the SAA results provide some information about prognosis. And that a Parkinson patient that has a positive SAA with or without a LRRK2 variant may have a different prognosis than somebody that has a negative SAA test. I mean, as you know from taking care of Parkinson patients just like me, patients are really very interested to know what to expect in the future. And longitudinal studies that follow on from the cross-sectional study that we did have the potential to answer whether there's prognostic information in the SAA result. And if that's the case, then we may find we do it more for patients clinically now because it will answer this really burning question that a lot of patients have.
Yeah, I think that's an important point. And I 100% agree. Patients are very interested in answers and information about what to expect over the years to come with their disease. And it can be really hard. And certainly those of us who take care of Parkinson's patients will acknowledge that, a lot of those answers are informing patients that their journey with Parkinson's is going to be unique to them, and that it's hard for us sometimes to sort of predict what will happen and when. And so if this can give us a little bit of information in that realm, I think that could be helpful as we sort of think about research studies to sort of jump off from what you and your team did here.
Yeah, I actually do want to just follow that comment up with a point about the asymptomatic at-risk individuals we followed in the study. As I said, we looked at people that had idiopathic hyposmia and also REM sleep behavior disorder. And in that, within those two groups, which we think are at relatively high immediate risk for getting Parkinson's disease, we found about 80% more or less had positive SAA results, which isn't terribly different than the rate of positivity amongst all PD comers, including the LRRK2 and the normosmic ones. But I think for these individuals, like if you were found that you had an abnormal sense of smell or were diagnosed with RBD and you wanted to know, is this something I really need to worry about, or is it just a sort of a benign form of these disorders, then the SAA could be quite informative now. And we found that the SAA was positive sometimes when the DAT scan was negative, indicating that it could be an earlier readout for Parkinson risk than a abnormal DAT scan would be. So in these individuals, we might actually have a clinical utility sooner than among manifest Parkinson patients.
Yeah, I'm glad you said that. And that's also another common consultation that I get in my practice, and you probably as well, are patients with, maybe coming from sleep medicine with a new RBD diagnosis and wanting to know, what does this mean with regards to their risk for neurodegenerative disease? And maybe this does help stratify that risk or give us a little bit more information about the future. Andrew, I wanted to thank you and remind our listeners that I've been speaking with Andrew Siderowf from the University of Pennsylvania about his paper in Lancet Neurology titled Assessment of Heterogeneity Among Participants in the Parkinson's Progressive Markers Initiative Cohort Using Alpha-Synuclein Seed Amplification, a Cross-Sectional Study. Andrew, thanks again for joining us today on the podcast.
You're welcome, Jeff. It's been a pleasure.
Hey, this is Jason Crowell with Norton Neuroscience Institute in Louisville, Kentucky. Thanks for listening to today's Neurology Podcast. Today, I'm speaking with Chris Gibbons. Chris is a neurologist at Beth Israel Deaconess Medical Center in Boston, and we're discussing a paper that he recently co-authored, published in the journal Neurology on April 11th. The title of the paper is Cutaneous Alpha-Synuclein Signatures in Patients with Multiple System Atrophy and Parkinson Disease. Chris, thanks so much for joining us today.
Jason, thank you very much for having me.
Before we get started, I want to mention that we're going to be discussing a skin test for phosphorylated alpha-synuclein. I don't believe we have discussed this on the podcast, at least not recently. This test is commercially available through a company, C&D Life Sciences, and we just want to acknowledge that, similar to Chris's disclosure in the paper, that Chris serves as a scientific advisor to this company and also has stock options in the company. All right, so Chris, we'll talk more about this skin test, but just let's get the headline first. Can you start by explaining, maybe in just one or two sentences, what it is that you're reporting in this paper?
What we're really looking at is, can we detect phosphorylated alpha-synuclein in the skin? And, the headline is, yes, we can. And in patients with synucleinopathies, and in this paper, Parkinson's disease and MSA, we can detect phosphorylated alpha-synuclein in the skin, but not in healthy control subjects. And the other major headline is that there's a different pattern between these two diseases. MSA looks pathologically very different than Parkinson's disease in the skin, and it's that cutaneous signature that allows us to really differentiate between the disorders.
Terrific. So let's maybe start by having you explain, if you don't mind, the skin test. So many in our audience may be familiar with this test by now, but again, I don't believe we've discussed it on the podcast. So can you please describe what's involved in these skin biopsies and how it is currently being used clinically?
For those of us who've been involved in the peripheral nerve field, skin biopsies have really been clinically available for several decades, really in the realm of small fiber neuropathy testing. And so using a standard 3 millimeter punch biopsy, you take small pieces of skin and you're able to study the skin under a microscope and look at the nerves within the skin samples and really identify whether there's the presence or absence of nerves that would indicate perhaps a neuropathy. But we discovered over time that proteins can be detected within these axons in the skin. So in this case, phosphorylated alpha-synuclein can be seen within the axons in these skin biopsies. And so we've been able to discover that using this technique, we can identify this abnormal or phosphorylated form of alpha-synuclein and confirm that in patients with synucleinopathies, we see this. And this has been studied in Parkinson's disease, MSA, dementia with Lewy bodies, and pure autonomic failure. And so we can really use the standard punch biopsy as a way to detect this.
And so having phosphorylated alpha-synuclein in these biopsies is sensitive, but not necessarily specific for a certain synucleinopathy, right? So if you have this phosphorylated alpha-synuclein, it would suggest there's some synucleinopathy, but just the presence of it doesn't necessarily specify which synucleinopathy. Is that correct?
Yes, exactly. So traditionally, when we see phosphorylated alpha-synuclein, it tells us that, yes, that abnormal protein is now present in whatever tissue source we're looking at. But as we know, the categories of synucleinopathies include Parkinson's, multiple system atrophy, dementia with Lewy bodies, pure autonomic failure, and of course the prodromal states, which can include most typically REM sleep behavior disorder, amongst other kind of prodromal conditions. And in prior work with our group and others, we know that the phosphorylated synuclein can be detected across all of these diseases. And in this particular paper, our question was really, is there a pathological signature that helps to differentiate amongst these different subtypes of synucleinopathy?
And so if I may try and summarize here, in this study, you took cohorts of individuals with multiple system atrophy, Parkinson's disease, and healthy controls, and you compared a couple of things, right? So you compared their immunohistochemistry on skin biopsy, how much phosphorylated synuclein they had, as well as the topographical distribution. So where was the phosphorylated synuclein located in terms of the location of the skin biopsies? And then you also compared nerve fiber density. So before we get into the data, just one question about what was your gold standard for categorizing Parkinson's disease versus multiple system atrophy in these individuals?
So we used clinical diagnosis using probable criteria, but we supplemented this with a number of additional ancillary tests. So all of the groups had expertise both in movement disorders and autonomic disorders. And so all the individuals were not of the equivocal category. These were, really clinically confirmed cases with supplemental autonomic testing, as well as ancillary tests. Some had cardiac MIBG scans and other things to help really confirm our best clinical estimate of the diagnosis. So it was really, that was the gold standard. These were not autopsy cases.
So what did you find when you looked at these results? When you gathered the data, what did you find when you compared these results in these different cohorts of patients? What was different about their immunohistochemical results with regards to phosphorylated synuclein? What was different about their nerve fiber density?
The interesting thing about skin biopsies is traditionally we've just been thinking of them as a way to look at nerves in the skin, and that's sort of the end result. What we're beginning to learn is there is a lot of information, and what I'm going to try and tell you is a little bit of the story of discovery that we've used in this process. So in these particular cohorts, we did 3 skin biopsies. We did one by the neck and then 2 sites in the leg, a proximal and a distal site. And we discovered that these 3 biopsy locations in prior work are useful in capturing the vast majority of patients with synucleinopathy. Now, we do understand and have previously noted that there were different patterns to the topographical distribution. So in other words, if I did a skin biopsy on the neck, that might be more likely to be abnormal in a patient, for example, with Parkinson's disease, whereas sites on the leg may be less likely to be containing phosphorylated alpha-synuclein. However, we'd noticed that MSA didn't seem to follow that pattern in the same way. So these were theories that we had going into this study. And so we did these 3 skin biopsies, and we quantified the amount of synuclein in each of the biopsies. And to our surprise, the synucleinopathy with the most deposition was actually multiple system atrophy. And this was a bit shocking to us because theoretically MSA is a central synucleinopathy. And so traditionally we would have expected very low to no phosphorylated alpha-synuclein in the skin. But in contrast, we found far more, exponentially greater amounts of synuclein across all 3 biopsies. And so when compared to Parkinson's disease, there really was a logarithmic increase in synuclein deposition. And in Parkinson's disease, we did identify this in the vast majority of patients as well. So we had 54 subjects who we tested, and 51 contained alpha-synuclein. So the vast majority had phosphorylated alpha-synuclein in Parkinson's, but it was just to a much smaller degree when we quantify this result. In contrast, all of the patients with MSA had phosphorylated alpha-synuclein, and the amount was much greater. And so when we talk about topographic distribution, we tried to express this in a way that was mathematically viable. So we looked at the different body sites, the neck and then the 2 sites in the leg, and we used a proximal to distal gradient as a way to really identify where the synuclein was deposited. So if you had your synuclein just in the neck region, that would be given a score of 1. And if we had just had it at the lower site on the leg, that would be a score of -1. And if it was sort of balanced evenly across, it would be a score of 0. So you can imagine sort of this proximal, which is +1, to distal, which is -1 gradient. And what we found is that in Parkinson's disease, the gradient was predominantly at the neck, sort of as we had noted previously, but this really confirmed it in this study. The neck seemed to be the vast majority of cases with Parkinson's disease. In contrast, MSA was much more widespread and so had a distribution that was much closer to 0, which indicates indicated that was evenly spread across all 3 biopsies. So with that information, we started to really see separation between groups. So if we were analyzing how much synuclein and the topographic distribution, that really allowed us to separate MSA from Parkinson's disease with really greater than 90% confidence. But we could also look at additional information in these skin biopsies. They contain small sensory fibers, the intraepidermal nerve fibers. They also contain autonomic innervation. So we looked at these different categories of nerves, and we also found that in Parkinson's disease, there tended to be a mild but length-dependent small fiber neuropathy that was present. This was not seen in patients with MSA. And so this was another feature of the biopsy that we could incorporate into our algorithm to help separate between these 2 groups or kind of subtypes of synucleinopathy. And so we could really see that the patients with Parkinson's disease were proximal predominant, lower levels of synuclein, and associated with a neuropathy, whereas MSA was more widespread, greater amounts, and no associated neuropathy. So given these pathologic features, what we're calling a biosignature allowed us to really separate between these groups very effectively. And so it was greater than 95% sensitivity and specificity to separate between these groups, kind of using this multiple layered approach of pathology. Of course, we do think that given these patients being very well characterized, not the groups of individuals that we're debating about, this will certainly be harder to do in those overlap cases or more challenging cases. And we think that's where the clinical features may continue to play a role. So we can add in clinical features about age, perhaps some autonomic function testing, cognitive testing, various other metrics might be, incorporated in such a thing. Things like the University of Pennsylvania smell identification test, the UPSIT, all of these are additional features that really could provide ways to help separate between groups.
Wow. So really incredible to think about potentially having a test that we can do for patients to try to answer this question that we so often wrestle with in clinic. Is this typical Parkinson's disease, or is this some atypical form, specifically multiple system atrophy? I want to ask you to expand on something that you mentioned, and I apologize in advance because this may just be me revealing my limited understanding of pathology, but can you talk a bit more about why these 2 synucleinopathies might have different topographic differences? So again, in Parkinson's individuals, it was primarily proximal exclusively. In individuals with multiple system atrophy, it was more widespread. Why, again, might their pathology explain that topographic difference?
These are ongoing areas of investigation. We have a couple of theories about why that might occur. So we understand or begin to understand the pathology, but it really allows us, I think, to ask some of these excellent questions about why this is occurring. So certainly in patients with MSA, we know that in the central nervous system, glial cytoplasmic inclusions are the hallmark characteristic of this, as opposed to kind of Lewy bodies and Lewy neurites that we see in Parkinson's and in dementia with Lewy bodies. So we know that the synuclein, as it accumulates, the diseases separate a little bit pathologically in the central nervous system, and perhaps that carries as well into the peripheral nervous system. We do see different subsets of nerves involved. And so one of the key things we do is ensure that the phosphorylated alpha-synuclein we're looking at is intraaxonal. So we want to make sure we're not picking up some artifact or something in the tissue. So we're ensuring that it is intraaxonal, which means we can then identify which nerve types are involved. And so one of the unique features in MSA is that the subepidermal plexus is involved. Now, if you're imagining a piece of skin, the very superficial layer, the epidermis, is where we find a host of small unmyelinated nerve fibers that tell us about pain and temperature. And just below that layer is something called the subepidermal plexus. It's a big array of nerves that run just beneath the epidermis and sends these small unmyelinated fibers up through the skin. In patients with MSA, we saw a fair proportion, the vast majority had some subepidermal plexus involvement. And in patients with Parkinson's disease, we really didn't see that to the same degree. So it was only a very small percentage. And that, does raise questions of, again, could we be misdiagnosing these 2 different groups? Absolutely. And And so these patterns are starting to really give us some understanding that the pathology does differ between these groups, and that certainly patients with MSA, we know it's a more aggressive, rapidly fatal disease. And so we wouldn't be surprised to anticipate that synuclein propagation occurs more quickly. And so as we look at these nerve fibers, we see that the synuclein doesn't tend to spread across the axon. It really spreads up and down the axon.
Let me ask you, you've talked about some of these already, but what lingering questions do you have now about the different distributions of this alpha-synuclein deposition in individuals with Parkinson's versus multiple system atrophy? Where do you turn next?
With this information, I think it really allows us to start to think about the array and range of diagnoses. And these are some of the questions, of course, that we do want to ask, because we're looking at the two subtypes that I think most people struggle with, Parkinson's and multiple system atrophy. But dementia with Lewy bodies is in this category as well, and in fact, maybe one of the most commonly misdiagnosed with MSA, in part because of the severe autonomic failure that's associated. So I think incorporating additional information amongst other groups and trying to understand, can all of these be differentiated, including pure autonomic failure, which, as some of you may be aware of, has a reasonably high phenoconversion risk over enough time. And so these patients who present with pure autonomic failure, perhaps this is just another prodromal synucleinopathy, like REM sleep behavior disorder, where over enough time, the phenoconversion risk to some other synucleinopathy becomes very high. And so looking at prodromal states and potential prediction and modeling, does a pattern predict what phenoconversion, might be like in the future, would be a really interesting question. So those are areas we're certainly looking at. We do have actually another very large study that's just coming to conclusion. It's still blinded at this time, but will be presented at the American Academy of Neurology this year. And we're looking at all 4 synucleinopathy groups and trying to understand whether these signatures between groups really do differ in such a way that we can distinguish all 4 based on the pathology alone. That may be a tall task, but we're optimistic that at least some signal will separate between all of these groups.
Terrific, Chris. I think it's pretty obvious how this might be very clinically useful in terms of trying to give patients more accurate diagnoses and narrow the differential, both now and especially looking forward as we hope for disease-modifying treatments for these different diseases. So really exciting to learn more about this and look forward to seeing the data you and your team present at the annual meeting.
Thank you. Certainly, these are early times in this analysis. And so as people ask us questions about, if I do a biopsy in my patient, what does this tell me? We're still at the point where we're being cautiously optimistic about the information we learn. And so I know people are very excited to get full answers, but just acknowledging that this is, again, an early study and we have plenty of work to do, but we are excited to continue to try and, learn more as we go forward.
Terrific. Well, Chris, thanks so much. I've been speaking with Chris Gibbons. He's at Beth Israel Deaconess Medical Center, and we've been discussing the paper he co-authored that is out in this week's journal, Neurology, titled Cutaneous Alpha-Synuclein Signatures in Patients with Multiple System Atrophy and Parkinson's Disease. Chris, thanks so much.
Jason, thank you very much for having me. It's my pleasure.
This is Stacey Clardy, your podcast editor. Thank you for listening and for letting us join you on your commute, while you're exercising, or even while you're brushing your teeth. This has been another episode of the Neurology Podcast, your best source of practical, relevant, and timely information for neurologists, clinicians, and patients.